The first speaker for the Voices of Medicine will be Dr. Patricia Teal.
Good evening, Dr. Kitts. It's always a hard act to follow my brother. But I'm here today as president of the medical staff and chief of surgery at the Douglas Hospital. And I'll start right out by acknowledging, as you all know, the system as it stands is not financially viable. The doctors here, they're all sitting behind me. We know the NHS song, another day older, deeper in debt. That's always the reason why all our services are being cut. But as far as we're concerned, delivery of care exclusively through the high-intensity acute care hospital, as the HIT document proposes, is probably the highest cost care method of delivery. We feel that to be visionary, to accomplish the goals of decreased costs and maintenance of quality care, a different concept of service delivery must be embraced. As far as the doctors are concerned, the NHS has prepared the HIP document, including recommendations that severely impact our community with little or no public and physician consultation. We look at the NHS document and we see that it lacks any detail on future hospital care and costs. It relies on an infrastructure that is just not here. For instance, the transportation. There are millions of dollars that would need to be spent on transportation before that plan is viable. There is no readiness to move forward with the plan of the NHS. We, the physicians, are concerned with the solution that the NHS has offered in place of an emergency department. We're concerned for the future of our outpatient surgery and our outpatient clinics. And we're concerned that the Douglas Memorial does not have a place as a hospital in the HIP. It's not fair and it's not safe for 30,000 of us. The present HIP model proposes cramming every level of emergency surgical and inpatient care into 3 full-service, highly expensive, so-called centers of excellence. But you notice the NHS really doesn't define centers of excellence. In fact, it's just putting the same old thing, but pushing them into 3 hospitals. That's all they're talking about, and at the same time, totally eliminating our GP-run small hospitals and outpatient surgery centers. We say, to address cost concerns, centers of excellence should be reserved for seriously ill patients or highest level emergency patients. Many patients that our doctors see are too sick to be cared for in the office, but they don't require a center of excellence. Their illness is not a mystery to their family doctors. They don't need a center of excellence. They can safely and efficiently get quality care with rapid discharge at our local hospital at a fraction of a cost to the taxpayers that it will cost to send them to a center of excellence far from their home and have an expensive array of tests they don't need. The experience in North America and in Europe shows less complicated care and outpatient surgery belongs outside of large acute care hospitals. Why? Financially, it's cheaper. The quality care is much better. I'm an ophthalmologist, and certainly outpatient eye surgery in smaller centers has been proven time and again to have a higher quality than in a larger center because we can be more efficient. Smaller centers should deal with the level of patients they're equipped for because they do a better job. Our proposal as physicians is that instead of the model the NHS puts forward, we should divide the hospitals in the NHS into levels A, B, and C hospitals. Niagara-on-the-Lake is already level C, having prompt care and community care centers. But the real change that we propose is that Fort Erie should be on a level with Welland. Why would we not be? That's right. We should be a level B hospital because we do it so well. Level B hospitals contain the core services of a small hospital. Outpatient surgery centers for a variety of surgical procedures that could be done safely on an outpatient basis. 24-hour emergency care, acute care beds and cardiac monitoring capability to support the emergency department and the family doctors, and of course X-ray and lab facilities. We proposed that there would only be 2 Level A hospitals. Why would we need 3? Hamilton is just down the road from us. The most expensive centers of care are these centers of excellence. We don't need 3 in the Niagara area. If we had Niagara Falls and St. Catharines, these hospitals would have 24-hour emergencies for primarily the most severe cases. Cases of this intensity in Fort Erie, Niagara-on-the-Lake could go to Niagara Falls. Cases of this intensity in Welland and Port Colborne could go to St. Catharines. Inpatient surgery and surgery in the seriously ill, full medical and surgical diagnostic capabilities would all be at the Level A hospitals. In summary, we feel that our alternate solution proposed approaches the future realistically. The highest level and most expensive care would be reserved for only 2 hospitals, eliminating 1 from our most expensive list. The reorganization we propose can recur with our current resources. It doesn't require a lot of ifs, such as extra government funds, which aren't there, for new primary care centers, community centers, or most important, a new transportation system. And finally, we want to tell you that the physicians here want to work with you. We want to be involved. We want to be part of the solution. Our takeaway message is make better use of the Douglas Memorial Hospital. Give us more work to do. Build with us a showpiece for health care. A local hospital is a health requirement, and if the core essence of a hospital is lost through a poorly thought-out plan, the health of residents of Fort Erie and the peninsula will be negatively affected. I want to thank you for coming, Dr. Kitt, and I want to leave you with that message. Involve us. We know the people, the communities, and the people who live here. We care for them. We have a lot to offer. Thank you.